I think the most important part that I've learned in my career is the ability to add new technology to provide a better operation for my patients. It's great to pat ourselves on the back and say that we use the new widget, but we want to make sure that it's really helping the patient.
Welcome back to another episode of the Spine Pod. B, we have a couple of these under our belt now.
We do. And this is a really special one. We got to sit down with Dr. Richard Chua in Tucson, Arizona. And what a cool journey he's had in his spine surgery career.
He really has. And what was so fun about this one was he was kind enough to invite us into his home to be able to have this conversation.
Absolutely. He's a really, really special, he's a special surgeon, but just a human being. He's such a great human being. He embodies all these characteristics that we care a lot about, right? He's a leader. I think he's a role model across the spine industry. He pushes forward clinical education and surgeon training, a lot of the elements that we need to train the next iteration of spine surgeon.
Yeah, absolutely. I think there's so many great nuggets to glean from this episode, anyone who's interested in spine. But what I also love is when we sit down with somebody who's just such a good character overall. And there's so much great life advice and nuggets out of this episode from Dr. Chua.
And he certainly has that. And he believes in a lot of the same concepts that we believe in.
Totally.
He's pushing forward MIS and he's pushing forward navigation and robotics. And then he talks about how all these technologies are coming together to coalesce and work with motion-preserving implants to provide a higher level of patient outcomes.
Absolutely. And what I love is like his dedication to training and education for the next generation of spine surgeons. It makes me excited to say, okay, someone like that is helping make sure that everyone, like the next generation, is moving the standard of care forward.
Absolutely right. And he just this year alone has had 8 speaking engagements.
Wild.
8 speaking engagements. So he is very well known in the community. He's doing a ton to give back, not just here in the US, but over in Nepal as well with the foundation that he works with. And just across the board, what an incredible character to be able to sit down with. A great neurosurgeon and has had a long career. And I think he's got a lot more to share with us.
He does. So enjoy this one with Dr. Richard Chua.
Dr. Chua, thank you so much for sitting down with us today.
You're welcome, Brady. Thank you very much. And Courtney, thanks for coming to visit.
Yeah, thank you for letting us into your home.
You're welcome. I hope this works out well.
Oh, it's perfect.
It is perfect. This is a special one. You know, when we look at what we're trying to accomplish here and patient education and getting the right technologies, the right people, there are certain people that come to mind. And you're one of those people. So we've been very excited to make this trip and come down and do this recording with you. So we really, really appreciate it. I think there's so many topics we could sit here and record for 4 hours, but we're going to condense it as much as we can.
Sure.
So that should be fantastic. But, you know, I think we want to jump in and hear a little bit about your background, you know, really high level. I think you are a massive proponent of education, surgeon education, and leadership and clinical training. I think you do these things and you do them very, very well. You're well known in the industry. You know, you speak at Seattle Science Foundation. I'm a little jealous. I got to see you wear the green jacket. You know, I always thought I'd get to wear that.
A couple weeks ago. That was awesome.
So, you know, doing the Spine Masters course and speaking on behalf of residents and fellows for Seattle Spine Foundation. And then for Medtronic, you do a lot of work for Medtronic. You were just at, was it the Mazama Spine Summit where you got to speak as well? So I think just this year you've had 6 or 7 speaking engagements. This is not new to you, but very well known.
You're stalking me, Brady.
I like to say we come prepared, but you do all these in kind of, I think, in the hope of training the next generation, right? You've been doing this for a long, long time. I'd like to bring it back to the start, hear a little bit about what brought you into medicine. I think it's always great to hear the story of, you know, what brought people to medicine in the first place.
Yeah, great question. So I was very, very heavily influenced by my dad, who is a retired interventional radiologist. And so growing up, he was sort of my professional and personal hero. I worked with my dad in middle school and high school and summers. I did research with my dad when I got into college. And so when I looked into going into medicine, that was what I thought I wanted to do, was be a radiologist. I loved the kind of work that he did. very high-tech field, CT scans, MRI scans, procedure-based. He was also a residency program director for a private residency program for radiologists. So very early on, I was exposed to sort of the private but also academic part of medicine, teaching residents and sort of establishing the next generation of physicians. And so that sort of was an imprint in me. And when I went to med school, my dad said, listen, you don't know anything about medicine other than radiology. Look at all the other specialties. Great piece of advice. Got into medical school. And fortunately, at my school at Indiana University, we could do elective rotations in our third year. And so I chose to do neurosurgery in my third year, not knowing what neurosurgery was, other than you got to be in the operating room. And I wanted to do all the rotations where I could be in the operating room. I thought I would like to be a surgeon and use my hands. And within a week, sort of fell in love with the neurosciences. We don't know much about the neurosciences. We don't really know that much about how the brain and spine works, even to this day. And so I wanted to go into a field that would always be teaching and I'd always be learning about how to take better care of my patients. In addition to that, I found neurosurgery appealing because of the work in the operating room under a microscope. And you probably hear surgeons talk about where's that Zen environment. And for me, with the lights off in the operating room, except me focused in the microscope doing an operation, whether it's a brain operation or a spine operation, is like my happy place, my Zen place. And then as I got into neurosurgery, I realized the breadth of conditions I can take care of, children all the way to adults, congenital problems to degenerative problems, traumatic to cancers and tumors. And so when I went into neurosurgery residency at Indiana University, it sort of set the stage for perhaps a private practice career or a partially academic career. And so I've really enjoyed how that's ebbed and evolved. But that's how I got into neurosurgery and love every minute of it.
I've always think it's fascinating. So my background's in neurobiology, and I always had this fascination with the concept that we've been to the moon, but we don't know how synapses and neurons in our brain work.
That's exactly right.
It's crazy. So I always thought that too. I was like, we don't know this thing that lives inside of us? That's unbelievable. I think that's
know. I don't know what the percentage is, but I believe we probably know maybe about 10 to 15% of the actual function of our brain and nervous system in 2024. Even though we have all this technology and immunobiology and immunotherapies and bells and whistles and enabling technologies in brain and spine surgery, we really don't understand exactly how a lot of things happen up here. And that's what I think is fascinating about the neurosciences.
Absolutely. Well, you have a special place in my heart, just being an Indiana guy. It's a special place for me, going from Wabash to Purdue and then IU. Can you talk a little bit about once you finished up school at IU and then your first practice? And you stayed in Indiana for your first practice.
Yeah, my wife and I are both originally from Indiana. We wanted to stay in Indiana. Grandparents are nearby. By the time I finished residency, we had our first daughter. So it was important to be near family. The other reason to stay in Indiana professionally was malpractice. The malpractice environment in Indiana was very favorable to physicians. And we don't get taught a lot about malpractice or how to avoid lawsuits and training. We don't get taught a lot about how to run a practice. So I wanted to stay in a place or go to a practice that someone else was doing all of that. And yet I was in a professional environment that was supportive of physicians who try to do the right thing. And even though sometimes we can have bad outcomes in what we do in neurosurgery and spine surgery, doesn't mean it should lead to a lawsuit. And so Indiana, we stayed in Indiana. I took my first job at a multi-specialty group in Lafayette, Indiana, where Purdue University is. My wife had gone to college there. I'd gone to med school there. Wonderful Midwestern college town. Great place to start a career and a practice and raise a family. That practice was 150 doctors. And very soon, within 5 years, I sort of got sucked into the leadership structure and I was the vice president of the group. Very quickly learned some of the business aspects of medicine, the politics of medicine, working with hospitals or not working with hospitals. And we actually broke ground and we're going to build our own 100-bed hospital owned by our group. And wonderful project. We worked on it for several years and then the project blew up. because of some lawsuits. And so unfortunately, we decided to leave Indiana because the litigious environment in a small community was going to probably take 5 to 7 years to sort out. And as the vice president of the group, I was named in those lawsuits, not just the group. So we moved west, came here to Tucson, Arizona in 2005, and I joined two neurosurgeons who were residents ahead of me, who had come out to Arizona after residency, and they had broke off from a large multi-specialty group here in Tucson and established a new group, 4-person group at one hospital, one office, with a real emphasis on great care for their patients, but a better quality of life for themselves and their family. And that was very important to me. So 20 some years later, we've been here, and that private practice ultimately dissolved within the last couple of years. And I found an opportunity to join the University of Arizona 2 years ago.
And so you went from Arnett Clinic up in Indiana down to Northwest Neurospecialist down here for the private practice part. And, I want to take it back a little bit. That leadership component that you kind of fell into, is that something that right when you started practicing, you were kind of looking for or wanting to do, or did that happen naturally? Because that's an additional workload on top of everything else you do.
It is. It's a great question. I think for me, it happened naturally. I think we're all probably, A-type personalities. We're a little bit probably over-controlling. And so I wanted to be part of the decision-making teams. So early on, I volunteered to be on committees at the hospital. I volunteered to be on committees in my group. And that just sort of naturally led to, hey, your opinion means something to us. We may not agree with you, but we'd like to have you on this committee, and we'd like to have you on that committee. And so I think it came naturally, but I think it might be part of my personality as well. I'm not the type of person or surgeon that wants to absolve all the decision-making to someone else. I think you, as a surgeon or physician in this industry, the more you know, the better you can make decisions for yourself and mostly your patients, and to help protect what we can do and what we can offer for our patients. So I think that's how I sort of have stayed involved in leadership type of activities.
Absolutely. And you've kind of stuck with the whole, leadership and training, professor of neurosurgery down here in Arizona. Do you want to talk about kind of the position that you're in now with University of Arizona and Banner and what that looks like for you?
Yeah, absolutely. So over my career, I've been very involved in surgeon education, either with consulting relationships with Medtronic, I worked a little bit with 3Spine, and some other companies. And that's been very helpful for me to understand where technology is coming from and where it's going. And you just don't always have time within a private practice to do that. So I've been involved in surgeon education. And then probably 6 or 8 years ago, I started developing a voluntary relationship with the University of Arizona here, the neurosurgery department. I started attending conferences and giving lectures and getting to know the residents and the faculty. There have been different periods where insurance issues have required me to take my cases away from my Northwest hospital. So I do an occasional case at University of Arizona, or what's now called Banner Health in Tucson. And then about 4 years ago, Banner Institution and the University of Arizona started aggressively recruiting me to come on board a little bit more fully. And so 2 years ago, I left my private practice, guys I've been in practice with for a long time and are still good friends, and joined the faculty. What's been a wonderful outcome of that is I still get to do a very private practice style of neurosurgery and spine surgery. I still get to do a lot of surgeon education, but now I get to fully educate and be involved on a daily basis the next generation of neurosurgeons and spine surgeons. Keeps me young, keeps me on my toes, and I've had to kind of get back and doing a little bit more reading and keeping up to date on the literature and studies and things like that. And I think what I've been able to do is maybe not teach every resident a new technique, but I can teach them about professionalism and humanism and how to take care of patients and how to be your patient advocate in the community with their other doctors and their other providers. And so I also, as a private practice doctor, was very involved in the business side of medicine, running our own practice, understanding insurance contracts, billing and coding, and all those important things that allow us to take care of our patients. And I've been able to bring some of that knowledge to the university, of Arizona and many of the residents and even some of the faculty. So that's been a real nice blessing that I didn't anticipate on and plan on. I now have availability for more resources for clinical research, and I'm hopeful that that's going to turn into some productive work over the next couple of years.
In the spirit of education, can you take a second just for anyone who's listening that doesn't know, like, what's the difference when you're saying like neuro versus spine and like there's also ortho? I think sometimes it can be confusing on like how do all of those mix?
Yeah, absolutely. Great question. So I'm trained as a neurosurgeon. So I did a neurosurgery residency. And in most neurosurgery residencies, we're trained to be brain surgeons, spine surgeons, and peripheral nerve surgeons. A lot of patients don't even know that. A lot of providers and medical professionals don't know that. At my program at Indiana University, we had a very broad spectrum of training, very high volume of surgery. So when I came out of neurosurgery residency in 1998, I felt like I could do just about anything other than pediatric neurosurgery, which required you to do a fellowship. So I did not do a fellowship in spine surgery, and because I was very well trained and well qualified. Orthopedic surgeons do an orthopedic residency, but they have a very small part of their training in spine during their 5 years of orthopedics. So if they want to be a spine surgeon, they'll go do a 1-year fellowship or a 2-year fellowship in spine surgery, and that should cover the breadth of spine surgery. So when patients ask me, well, what's the difference between an orthopedic spine surgeon and a neurosurgeon? I tell them, it's kind of the difference between going to Montessori preschool and regular preschool. We all ended up at kindergarten. By the time we get to kindergarten, we should all have the same tools.
That's a great analogy.
To move forward. So we do have neurosurgeons, though, now that do fellowships, 1 or 2 year fellowships, particularly if they want to be in a high-powered academic environment, do a lot of research. Or they have a niche in spine surgery that they really want to develop an expertise early in their career and develop that through the rest of their career. So complex spine surgery or deformity surgery or pediatric surgery or cancer surgery of the spine. I'm far enough in my career that my niche has been sort of enabling technologies, motion preservation, minimally invasive surgery, and some of the other technologies like navigation, robotics. But it's a great question because you can just Google spine surgeons and you'll get a lot of different names and a lot of different backgrounds.
Well, you just said some of our favorite words: motion preservation, enabling technology. Those are all things we love to talk about.
It sure is.
Very, very well versed.
It sure is. And that's exactly what I wanted to jump into. So you started practicing in 98. So you started practicing. Were any of those technologies available when you started? That's where I want to start at, because that's how much it's changed in the time that you've practiced.
So unfortunately, I'm going to age myself. When I trained between 92 and 98, there was no such thing as a lumbar disc arthroplasty. I'd never heard of it. Cervical disc arthroplasty, never heard of it. Pedicle screws were new. When I was a resident, there was controversy about pedicle screws, and you may know there were lawsuits regarding putting in pedicle screws in patients. There were some TV shows, investigative reports, 2020, on the legality and the appropriateness of spine surgeons putting in rods and screws in patients. So I trained in that era, and in fact, during my residency, most of the training I received about putting in instrumentation in the lumbar spine was done by orthopedic spine faculty. So I finished in 98 and had to learn, as we do with continuing education, new technologies, including pedicle screws. Shortly after that was the what we called the cage rage, which was anterior lumbar fusions with titanium cages. So I learned and picked up that technology. And probably very early on, I worked with industry to create a learning pathway. So in addition to going to spine conferences and neurosurgery conferences, industry played an important part in teaching me or making me aware of new technology. I remember as if it was yesterday, a company said, "Hey, Dr. Chua, we've got this minimally invasive technique to do lumbar discs. Are you interested in learning?" Absolutely. Let's do it. Did a cadaver lab, saw the value, talked to some surgeons who were early adopters. And within a year of that, I was hooked. And now I started converting my practice into minimally invasive techniques in 2004. Then the next thing I remember is about 6 months later, a rep said, hey, our company's now got pedicle screws that we can put in percutaneously without navigation, just C-arm. And I thought, wait, we're doing fusions and putting in instrumentation through little tubular retractors? That doesn't sound safe. And of course, I had to prove myself wrong by learning the technique, choosing my patients wisely. And within 6 or 12 months, all of a sudden I'm doing MIS lumbar fusions with percutaneous screws. Unheard of in 2005. I was fortunate enough to practice in a hospital where we had navigation for brain surgery and cranial surgery. So all of a sudden, navigation starts having applications in the spine, software and hardware. Well, let's give that a try. That sounds like a good idea. It makes me more accurate in putting in screws, makes my surgeries more efficient, reduces the complications, reduces the amount of radiation I expose myself to in the operating room and the patient. That sounds like a good idea. Let's go learn it. Let's go figure out how to use it. Let's try to use it and do it well. And then that just sort of started my career on adding technology as it came about. I remember very vividly when cervical disc arthroplasty came out. I was not an ultra early adopter, but I think a relatively early adopter, 2007, 2008.
It's pretty early, yeah.
And unfortunately, great results. And the science was early and was really good, but we had so much pushback from the insurers. And so that made it a troublesome thing, but things started changing again, the second phase of cervical disc arthroplasty. Now, I'm such a big believer in motion preservation. I think for the last 3 years, I put in more arthroplasty devices than I do fusions for the cervical spine. Very interested in the technology that's getting studied right now with lumbar disc arthroplasty, and I'm hopeful to be an early adopter. Unfortunately, I couldn't be an ultra early adopter, but very, very much looking forward to that. And I think the most important part that I've learned in my career is the ability to add new technology to provide a better operation for my patients. It's great to pat ourselves on the back and say that we use the new widget, but we want to make sure that it's really helping the patient. And my philosophy has been, just because someone says it's great doesn't mean it's great. I've got to figure it out. I've got to figure out how to use it properly. I have to prove it to myself. And if I've proven it to myself, then the sky's the limit. And that's been actually the fun part of the practice and the career of neurosurgery, especially in spine.
I think something you said is really interesting, and I'd love your thought on it. Saying like the pedicle screws was kind of like, we don't know. Now, today, you wouldn't even think like that. It's just standard, right? And it's like, I got a new pedicle screw, I've got a new pedicle screw, I've got a new pedicle screw. But I would love to hear your thoughts on innovation in spine can be slow. You said motion preservation, cervical, we had those pushbacks. What have you seen of, like, we're very passionate about motion preservation. We've seen it slowly try to make its way. Fusion still has a stronghold across the industry. What have you seen in your time in practice where innovation has tried to push forward, and how the industry or your colleagues have interacted with that?
Yeah, it's such an important philosophy, because there are examples in spine, for instance, where there's a great product, there's a great technique. We maybe didn't study it as well and provide the data.
Yeah.
And if we don't provide the data, then we can't get the insurers to buy in and approve it. We can't get the FDA to approve it. And we're a different society than Europe and Asia, and we have a very complex way of bringing new products to market. So I've seen some terrible failures of things that were really good, and I've seen some successes with things that aren't very good, and all over the map. I can tell you, I remember lumbar disc arthroplasty came around shortly after we started doing a lot of anterior lumbar surgery for fusion. Well, we figured out how to do the exposure by having vascular surgeons do the exposure. We get there and we just take the disc out and put an implant in. It's as simple as that. Well, lumbar fusion anteriorly was very different than arthroplasty in the early days. And a lot of surgeons, including myself, who did anterior fusions in the lumbar spine early, found that the disc arthroplasty surgery was different. And so now you can't take a good anterior fusion surgeon and make them automatically a good arthroplasty surgeon. So that's a good example of where I think as a specialty or a society or providers, we didn't do a good enough job of preparing that surgery to go prime time. And so now, fast forward 20 years later, there's probably a handful of places that are doing anterior lumbar disc arthroplasty, but that's it. In my community in Tucson, Arizona, no one does anterior lumbar disc arthroplasty. And I can think of a lot of other examples where that's been a problem. On the flip side, surgeons working with industry have been able to push and evolve a lot of great products like cervical disc arthroplasty, like navigation, like robotics. And I've been around long enough that I sort of know the key players and the engineers and the companies. And I think that relationship between industry and surgeons has become so pivotal to advance what we can develop for our patients. The engineers are amazing, bright, super smart people, but they're not physicians and they're not surgeons and they don't take care of patients. So I've really enjoyed that relationship in my career. And I use the phrase a lot, but when I have dinners or I meet with some engineers about different things, I mean, I walk out of there just feeling like the dumb person in the room, not even close to the smartest person in the room. And I think that type of working relationship is so important for how we're going to make things better for our patients.
I love that.
It is. It's really fascinating. I think we talk about this concept a lot, and you just highlighted it really well, of how many different components need to come together to not just bring the product to market, but to bring it to market successfully, right?
Right.
Because there's this huge gap between creating a product that can have impact, whether it's a motion preservation device or navigation or robotics or pedicle screws, and then actually implementing it, right? And like you said, I think you have this curiosity and this natural learning. We're seeing new technologies now, whether it's robotics or different motion preservation devices that weren't around when a lot of these surgeons trained. So it's not that they don't want to use it, it's that it didn't exist.
Yeah.
Right. So if you don't have time to go learn and train on those things, it's tough to correctly implement it into your practice safely, efficiently, for your best patient outcomes. Because we always talk about a lot, it's a tool, right? And so different surgeons use tools in different ways, and it's what's the tool works best in your hands is what's going to be best.
Exactly. And to use the tool analogy, right, I can get the same tool at Home Depot that I can get it at Lowe's or Ace Hardware. But so my relationship with the guy at Ace Hardware to help me understand how to use that chainsaw, if I've got a better relationship with Ace Hardware to teach me how to use a chainsaw might be cheaper at Lowe's, but I might go to the Ace Hardware because of that relationship. So it's interesting too. I think the perspective on this side of my career, looking back, we used to think that a lot of innovation happened in the academic world. That's where you had resources for basic science research and clinical research. And those are the really, really innovative doctors and surgeons. And I think for the most part, that can be true, but it's not always true. And I think looking back at my career, there's been tons of innovation where there's been collaboration between private practice doctors and industry, or private practice doctors and hospitals. And I think it's no longer this idea that, the private practice people just kind of are in this lane and the academic surgeons and practices are in this lane. In order to advance our field for the most important reason, which is to take care of our patients, we got to break down some of those barriers and silos and work better together.
I think that's so true. And I think a lot of it is, just think of the world overall. Technology moves so fast now, and you have a little bit more ability to move quicker. Like if you're in private practice, versus like in an institution where there's a bit more red tape, and which is good, right? You want to be able to like be safely moving forward. But even at 3Spine, the Modus device, it was created by two private practice surgeons, and they were like, I don't want to keep doing fusion for my patients. What's something else I can do? And came up with this idea 20 years ago. And then they worked with Medtronic to make that come to life, right? And so I think that's so true of like starting to break those down and seeing like it's not all just happening in one space, and everybody needs to talk to each other.
Right. And I think ultimately that's how we get to the best result.
Yeah.
Probably get there, but it's going to take a lot longer if we're working in these silos.
Yeah.
So you talk a lot about being an early adopter for these technologies. And I think, there are a lot of hurdles that make it easy to not be an early adopter. What are the what are the parts that you're looking for when you're adopting these technologies early? Because like you said, at the end of the day, you have the patient's best interest at mind and the best possible outcomes. So sometimes at the start, there's a little bit of give and take there on you have to be have a certain amount of adequate training to say, I'm ready to implement this thing. How are you able to kind of get through those hurdles, or what are you looking for as you're being an early adopter in these technologies?
Yeah, great question. I think the first and most important thing is you have to be comfortable with yourself. Your choosing of patients or indications of surgery, the type of equipment that you're going to use. You need to be comfortable with your own skill set. We can't all do everything. I fully admit there are some things that I just can't do and I will never be able to do and do well, and that's okay. So I think you have to have a good understanding of that. And then I think we have to take away a little bit of the arrogance that we have as physicians and surgeons and say, I want to provide a better product or a better procedure because it's right for my patient. And how do I get there? Do I read about it on PubMed? Do I watch a YouTube video? Do I listen to a bunch of podcasts of some of my favorite surgeons who are on social media? Or do I take the time to go learn how to do it? And how do I do that? I've got to take away time from my family and my practice to be able to do that. But you have to make the effort to be able to get to the result. And for me personally, I think what's most important for me and has been successful to me is I can't just believe that Dr. Hodges says a Modus is going to be better than widget B, right? I need to prove to Rick Chua that I can make product B be better than Modus or Modus better than product B. And no one can tell me what that's going to look like. I have to prove it to myself or disprove it to myself. And I think that's incredibly important. The downside of new technology or learning is our own ability to say, I'm as good as I'm going to be, or I'm already pretty good. I don't need to be better. I don't need to be faster. My results are great. My patients do wonderful. I hardly have any complications. And I think it really requires an introspective person to say, you know what? Maybe I can do better. Maybe I need to take the time to learn and prove that I can be better, or maybe I can't be better and I'm okay. And I think that's the biggest challenge I see in surgeons adopting new technology and techniques is pulling down their own barrier. And which is one of the reasons why I love doing so much teaching with the residents and fellows. And as you said, I'm going to Seattle Science Foundation for their residents and fellows course because they're all sponges. They're all just looking at you like, teach me something, anything. And so I think that's maybe the most important thing I can teach in this part of my career is for surgeons to figure out how to be a better surgeon tomorrow. And I tell my residents, I've done 3,000 lumbar fusions, minimally invasive, tubular retractor, navigation, and now robotics. That doesn't mean I'm still a great navigation robotic surgeon. I can be a better surgeon for my next patient next week or my patients next year. And I think if you're not continuing to challenge yourself to make yourself a better surgeon, then you're going to have a hard time adopting new technologies for the right reason.
I think there's something that we resonate with a lot hearing from you, and it's one, the humility aspect. I had a quote from you from one of your Seattle Science Foundation talks. You are never too old or too good to stop learning. And I think there's a lot of people that would look at you and say, you're an expert in your field. You're doing as good as you possibly can, but the level of introspection to highlight how important clinical training is, adopting new technologies, jumping into those. And I think your buy-in to promote and provide better patient outcomes, right?
I mean, that's ultimately what it's all about, right? And I think too, when I go to teach at courses as a faculty, I say this and it's true, it's very much a cliche. I learn maybe more coming out of those courses as a faculty member than I really gave or taught. I don't admit exactly what I've learned because I want to put that in my back pocket. And that philosophy probably came from my dad. I remember like it was yesterday, I called him and I said, hey, I got accepted in the neurosurgery residency, right? And there was a lot of cheers and celebration. And then I remember the phone conversation, hey, Dad, I'm graduating from neurosurgery residency. And his reply was, congratulations. Don't think you know anything about neurosurgery.
Wow.
You just finished your residency. You're going to learn the majority of what you're going to use in practice of neurosurgery once you start the practice of neurosurgery. And I can hear him telling me that, and it's absolutely true. I think we all come out of residency after, 4 years of college, 4 years of medical school, 7, 8, 9 years of residency and fellowship, and you think, I know a lot. You don't know anything. You don't know anything about taking care of patients and then adding and evolving technologies and techniques. So that philosophy that kind of came down through my dad's been very important for my career.
I think that's just a great philosophy for life,
Agreed.
just like taking that nugget and be like, we should all continue to be learners. And a lot of times it's like, okay, I finished school, I'm done. And how much time do we create in our life to continue to learn new things? Because it's so true. I was thinking like, oh, wow, really, what did I use from college that I use today for, what I do for a career? And it's like, maybe 5%.
Maybe, right?
Maybe,
Yeah. And I think I'm a dad, I'm married and have 3 grown daughters. And when you become a parent, I can sort of see the parallels of what I've done professionally and how I've kind of been a learner but I can see a lot of parallels in that and also being a parent. You don't know how to be a parent the first time.
Yeah.
You learn some things, some good, some bad. You make some mistakes. You have some successes. You hope you're a better parent for the second kid. You make some mistakes. You have some successes. You have some failures. And then you think, okay, I got it really pretty down good by the third kid. And you make some mistakes and you have some failures. And I think there's a lot of parallels to being a parent and in this career of neurosurgery and spine surgery.
I think it's spot on. I think it's such a great point. And I think the tough part is it usually takes work outside of what you're doing on a day-to-day basis to learn those new aspects, right? And that's why it's challenging because you have to actually make the time to do that. Like you said, you have to take time off your practice to go learn something. That means you're taking time away from your family. You're traveling. You're already sleep deprived, but it's like, oh, well, I'm going to go take this 2-day course. But there's a level of sacrifice in order to provide better patient outcomes as well. I think the other point that you brought up that I really, really like, and I think this extends beyond healthcare, is the importance of having people in your life that you can look up to and learn from, right? You talk about your dad and being able to learn as much as you did from him and how many nuggets he's given you. I think you have now carried that on in being a leader in the education and training space. And I think that is something outside of healthcare that is so important, is essentially having that shining star or mentors in your life that you can learn from and do the same thing that you did throughout your career.
Yeah, listen, it sounds kind of cool and sexy to be a brain surgeon or a spine surgeon, but at the end of the day, it's a job and it's a career and occupation. It's no different than being a marketing person or a salesperson or anyone else. And I found a lot of value in thinking about how I did last year and how I can make next year a better year, whether it's as a surgeon or a partner or an educator or a husband or a dad. And I guess looking back, that philosophy started somewhere early, probably from my parents. And to this day, I remember when my kids are sort of middle school and high school, we were getting away from the New Year's resolution type of idea, right? Because we all fail at New Year's resolutions. Yeah. So I started having conversations with each child. And now I have that conversation with myself every year. I look back and say, okay, how did I do this past year? For my daughters, I'd say, how were you as a sister, as a student, as an athlete? How do you think you did this past year? And we'd talk about it. And then I'd say, okay, fine. What do you want to do better this year? How can you make yourself a better student, athlete, sister, daughter? And I think I've found myself doing that in my career. And now what I've learned with the residents, for instance, is at the end of every case, even if it's a case that I've done 5,000 times, like a minimally invasive discectomy, I'm still thinking about how I could have made this better tomorrow. And I think that's important to have that concept top of mind for the residents so they get into that habit. Just finished a big complex surgery last week. And while we're closing, the resident and I, we started talking about, okay, could we have been more efficient? Could we have positioned the patient better? Could we have made the opening and exposure better? Could we have done the surgical planning better? And if at the end of the day, at the end of that case, the answer is no, that's great.
Yeah.
I mean, that's an amazing feeling. But if it's, yeah, we probably should have done this before that, well, let's do that next time. And let's see if that makes a difference and does it make it a better product that we're providing to our patients. So I love that challenge.
You're 26 years into practice and doing that every day. I think I mean that.
You just made me.
I mean that in the most complimentary way, but to be that far down the line where so many people would say, you can, and it's easy. We talk about this all the time, like in your day-to-day life of just, 6 months pass and a year pass and 5 years pass. And you have to really diligently sit back and say, what did I do yesterday, or how can I do today better than yesterday? And I think, in the field of surgery, I'm not sure if there's a more important place to do that exact thing every single day for patients.
Well, that's exactly what the type of surgeon and provider a patient wants, right? That's what you hope for. Like, I'm putting my life in your hands. And I love that you say that's my Zen place. Like, to me, I'm like, that would be my most just stressed out, like not Zen at all. But what you want is the surgeon that's like, this is where I am Zen. This is where I feel best. And this is where I'm going to say, how do I continue to be better? And that's, we're not all created equal. So it's great to find someone that has that perspective and is providing care like that.
Well, thanks. Again, a lot of hard work. Some of it's just, philosophies that are passed on down from my parents and other mentors. It's served me well. But I have to tell you, some of the most fulfilling things I hear from patients are, gosh, you seem so comfortable and relaxed with the surgery that you're going to do on me. I'm like, well, I need to be. I should be. And I often tell my patients, if I've got a good plan and I've got a good backup plan, everything should be just fine. Right. But it's when you sort of walk in without thinking about it and planning and strategizing, even for the simplest surgery, is when things can go bad and patients can be at the raw end of that bad outcome. So I think it's been helpful. And it may have been my personal approach to things, like when we go on a family vacation, I'm kind of the OCD guy on where are we going to stop for gas and where am I going to get my coffee and which ice cream place are we stopping at? And I'm thinking about that weeks before we actually take off versus just loading up the car and going.
There's a lot of different aspects. I think that comfortability comes from the preparation and the training and that refinement beforehand. And I think that's where that all comes from. I want to talk about some of the aspects that you are a true expert in. And we could say just neurosurgery in general, but the things that you really push forward: MIS work, navigation, robotics. What were some of the early things that you saw? Was it patient outcomes? Was it the technology alone that said, I want to plant my stake in this ground and start pushing this forward?
Absolutely, it was patient outcomes. MIS techniques were coming out. Kevin Foley was popularizing it. Dr. Maurice Smith out of Memphis in the early 2000s, which was right when I finished training. And I trained as an open spine surgeon, open surgery, open lumbar fusion, open discectomy. Well, as part of a neurosurgery practice, you collect your cases for the first couple of years to be able to submit them to the boards in order to sit for your oral board exam. And in that, we had to take notes of every patient we did surgery on, their 30-day outcome, 60-day outcome, and 90-day outcome. So for a herniated disc, we usually saw patients one time, and that was it after surgery. And I noticed a high percentage of my patients for open microdisc surgeries had some residual back pain or buttock pain after surgery. No one taught me why that is. They just said it is, and it'll go away. Well, I started looking into the MIS technique, started using the MIS technique, and realized that percentage of patients with that pain disappeared at their first postoperative visit. So I proved to myself that there was something about the MIS technique that provided a better clinical outcome. And then that's just the first example, and there have been several other examples. When I look at navigation, I saw a better outcome because it made me more efficient and more accurate in putting in pedicle screws. And we know that if we have a misplaced pedicle screw, it might be okay, but it might be an adverse patient outcome. It might require more surgery. It could result in a neurological deficit that's permanent. And not only is that bad for the patient, but there's a cost factor for that type of outcome. So navigation showed me that I could be better at putting in pedicle screws safely with less trauma, less complications, more efficiently. And because it molded very well into an MIS technique, patients are getting out of the hospital sooner. So from the global standpoint of healthcare resources, I'm actually saving the hospital system money because my patients are getting out of the hospital sooner, even though I might be using newer, more expensive technology. And then we transitioned into robotics, which I've been doing for about 6 years now. And it's just another level of accuracy, preoperative planning using predictive modeling and artificial intelligence, which has been around for a long time, but is just now kind of getting into the medical field. So when we add the increased accuracy, predictive modeling, artificial intelligence, efficiency of surgery, now I can spend a little bit more mental health time doing the more challenging parts of the operation, which is decompressing the spine. The most recent transition is using the robot to plan the decompression. So robotics has been around now for about 6 to 10 years and got a lot of criticism for being a very expensive drill guide to put in a pedicle screw. Well, now I can use artificial intelligence, predictive modeling, and a computer to plan my decompression using the robot. And with the precision of the computer and the execution of the robot, I can do the hardest part of the operation, the most dangerous part of the operation, using the robot with a better clinical outcome, more efficient surgery, and ultimately help save healthcare resources. And so that's been the really fun part about adding new technology to my practice.
I think on top of that, what's really exciting about all these enabling technologies is the way that it's opened up the spine for us for new types of treatment, right? Where, things weren't available before. You talked earlier about we maybe know 5 or 10% of like what the ability of our brain is to do, but there's still a lot we're learning about the spine,
Absolutely.
right? And how it impacts our entire body. And I think all these technologies are helping us be able to look at the spine in a different way and say, is there another way I can treat this? Or are different devices possible now that weren't available or even possible, 10 years ago, maybe even 5 years ago? I'd love to hear a little bit of your thoughts on that and what you see coming forward.
Great question. So to answer that, I'm going to go all the way back to when I was in training for cervical fusions and lumbar fusions in the 90s. We rarely talked about adjacent level disease. We didn't really know much about it. So there wasn't a whole lot of talk about, well, we need to do a good operation, but prevent the adjacent level disease. Well, now we have a much better understanding of biomechanics, both cervical and lumbar fusion. So what I'm really excited about, and I hope will to come to fruition, is the ability to pull together navigation, predictive modeling, artificial intelligence, computer planning, navigation, robotics, and lumbar disc arthroplasty. So getting away from the anterior approach, which is a good operation, but has its benefits and risks, but going back posteriorly, where as spine surgeons, we're all really, really comfortable. And so I love the idea about bringing all these technologies in and doing motion preservation in the lumbar spine. Lumbar fusions are great operations. They will always be great operations. And there are some patients that are going to need a fusion and will never be a candidate for motion preservation. But I think there's probably a lot of patients that we do fusions on that could get by with or do well with motion preservation. So now if we understand that concept and that strategy, well, why shouldn't we use all the new fancy bells, widgets, and tools to be able to accomplish that? As you both well know, lumbar disc arthroplasty through a posterior approach is evolving. There is a product, but it's a pedicle screw product. So now we're going back to the whole idea of putting in a pedicle screw to be able to get motion preservation. But with Modus and 3-Spine, gosh, can we somehow put together navigation, minimally invasive techniques, robotics with the precision and accuracy to perfectly place a posteriorly placed or through a posterior approach, a lumbar disc motion preservation device? The answer is we should be able to. Now we have to prove it to ourselves that we can do it well, and do it safely. That's super exciting.
I think what gets us out of bed some days is those exact topics. You've got all these technologies, and we talk about timing a lot in healthcare and just in life in general. All these technologies are coming together at the right time, right? So now you've got navigation, you have robotics, you have MIS procedures, and you can use them to place a motion preserving device, hopefully in the future, right? But they all are a stepwise process in the right direction, right? They all add a little increment of better. And that's what we're trying to do, right? Is ultimately get to this aggregated goal of higher and better patient outcomes.
Absolutely. And that is perhaps the not only challenging part of what we do in spine surgery or neurosurgery in general, but it's also, to me, the most fun part. I look back in some of the talks I give about technology and how I've adopted technology is the fun part. Spine surgery can be kind of grueling. It can be very repetitive. And honestly, I don't know if any of your other um, guests have said this, it can be kind of boring. And, I don't want to be bored when I go to work. I work hard. I put in a lot of time to do what I do. I can't be bored. And so some of this is not only just professionally gratifying, but it's very personally gratifying to enjoy and have fun in the operating room. And I think that's an important part of being good at what you do is you got to enjoy the good and the bad, and you have to have some professional or personal enjoyment and fulfillment out of it.
We've brushed on MODIS as well, but I do want to highlight. So MODIS is going through clinical trials right now, just finished up enrollment, and a posterior approach total joint replacement for the lumbar spine. So we're talking about motion preservation. I think some of these topics get used interchangeably, but we have, like you've said, cervical disc replacements that have been around for a long, long time, are very widely adopted now. We have multi-level reimbursement for those, and we're getting that kind of buy-in, right? And I think cervical disc replacements are moving along and moving forward. Lumbar discs, for the right patients, do very, very well when you have the right exposure, surgeons, and can do those things and do fantastic. They're just, slowly moving along. And now we have a TOPS device, which is a posterior approach facet replacement. And hopefully we're getting this place where we will have a total joint replacement, just like we have for knees, just like we have for hips. And what I get so excited about, you talked about this in one of your presentations as well, is how your practice has changed over time. You brought up this concept of when you started your neurosurgery kind of journey, the goal was pain reduction, right? That was the goal, is pain reduction. And now you talk about all these other aspects that we're trying to get out of surgery. Talk about quality of life, returning to work faster, lower operative time, lower blood loss. Those are some of the aspects that we're trying to get to, and how care has evolved so much over time from when you started in your practice.
Yeah, I can actually see the slide in my mind that you're kind of quoting. Yeah, and it's true. When I was training, 2 goals for spine surgery were reduce the pain and make the neurological deficit better. That was it, and avoid complications. Now that list of goals for every surgery includes those, but is do it efficiently, get them out of the hospital quicker, have less complications, get them back to work faster, get them back to doing the things they love faster, make it a financially improved solution, because that's what we need to do in our society as we move forward. And those are all incredibly important. And if you sort of practice and have a career where you put blinders on and ignore those, you're just going to get lost. And I think it's going to be a very unfulfilling career. I'd like to tell the residents and teach the residents that you should not be doing the same surgery I'm teaching you 10 years from now, because that's how fast we're evolving. And if you're doing the exact same thing that I taught you 10 years from now, I wasn't a bad teacher. You weren't a very good student. I also tell my residents, having been in practice now over 25 years, the only operation that hasn't changed for me, and I do cranial, spine, and peripheral nerve, is a carpal tunnel surgery. I do it the exact same way that I was taught by my professors 28 years ago. But every operation in spine and every operation in the brain has evolved and is a very, very different operation for me now than it was back then. Again, I try to impress upon the residents that that's the evolution of your continued learning in your career, evolving, finding what works and what doesn't, working with industry, finding the technology or the technique, and improving your care and the surgical procedure, again, for the patient's outcome. And if you're not doing that, you should be doing that.
That's good for patients to know too.
Absolutely.
We talk a lot about like, what are the questions patients should ask to determine if this is the right surgeon for them, or they have the knowledge and they've done, the growth over their career, so that they're getting all the options available. If they are doing the same thing, I don't know how you would actually ask that to a surgeon, but it's a good point of like, if someone is still just stuck on what they learned, out of school 20 years later, that means something.
It does, and it's an interesting perspective for the patient. And most patients don't ask us those questions. I don't think they know how to ask that. They sort of look for the simple things that are on the internet. Are you board certified? Do you have a license? But what I find is the best patient advocates to come see me are my patients. So with all due respect to marketing, I can have a marketing director try to roll my practice up and splash all over the internet and YouTube and TV commercials and billboards. But at the end of the day, what's really worthwhile is that patient experience. And if you're a good surgeon and you're a good person and you deliver a great patient experience, your patients are your best marketing tool. Yeah. And since I've been in Tucson for a long time, I love it when a patient at the end of a visit, not at the beginning of the visit, tells me without me asking, Dr. Chua, I came to see you because Bobby, my golf buddy, had surgery by you, or my neighbor's aunt had surgery by you, and they may not know what the surgery is, and it's completely different than what they're here to see me for. But that's very, very meaningful to me that patient told someone else, hey, you ought to go see Dr. Chua.
Word of mouth is the best marketing.
Absolutely.
Yeah. Put me out of a job.
Absolutely.
I think on that thread, though, one concept that you had brought up previously is some of this AI, driven work and data-driven work that I think we're going to see this movement towards. You recently spoke at a Medtronic event. I think it was Luminate, talk about ABLE and these different concepts coming together. I think we're going to see this move towards more, maybe customized isn't the right word, but patient-specific or pathology-specific devices, technology, et cetera, where in the concepts that you talk about, we're not going to go into surgery and guess what's going to be the right procedure or device. We will know based on a patient's pathology, based on their, previous whatever they've had done, we're going to know what's going to go in best. Do you see that trend happening? Are there other things that you think are the future of what spine is coming?
Absolutely. So you just kind of tickled me here for a really fun topic. So right now in spine surgery, I have the ability to create patient-specific implants. So I'll take their preoperative x-rays, CAT scans, MRIs, use a computer, design the operation. It might just be a one-level lumbar fusion. I can design the operation. I can design, using predictive modeling, artificial intelligence, the implants. We can have those implants manufactured and placed into the patient to meet a lot of criteria, spinal pelvic parameters, improve those things based on what we know in the literature of hundreds of thousands of patients. But if I go to the literature and it says, well, Dr. Chua, in an L4-5 fusion with a grade 2 spondy, you need to make your SVA and your PIL mismatch this number, I can try to do that. But those numbers come from hundreds of thousands of patients by other surgeons. But if I have the ability, and I do, to have a registry of my patients and my data, my patients preoperatively, my patients postoperatively, now you can imagine artificial intelligence and algorithms will say, okay, Dr. Chua's grade 2 spondies at L4-5 typically do well with this implant, this degree of correction, and this alignment. And now the computer takes Rick Chua's data of Rick Chua's patients and provides me with the plan for Mrs. Smith next week. You can't get any better than that, I don't think.
No.
And to me, that's the super exciting part about where spine surgery and technology is moving, is to individualize the operation. Unlike when I trained in the 90s, every herniated disc surgery at L5S1 was the same incision, the same exposure, the same retractor, the same bone removal, ligament removal, and removing the herniated disc, even though they were different types of herniated discs. So I love the idea that we're getting to really, and it's a cliche, personalized medicine or personalized surgery.
And I think that's where motion preservation fits into a lot of these enabling technologies too. We see this a lot, I think, I hear a lot about it in industry. Cervical discs is a great example, right? There's 8, 10 cervical discs on the market. Everybody's got a different opinion on what works best, what doesn't work best. But truthfully, it should be an objective measure, right? It should be an objective measure based on your data and your outcomes.
Right.
Like,
and it's my data and my outcomes, not Dr. Ziegler, who's an amazing cervical disc arthroplasty surgeon who's put in 10,000 of them. And I've only put in 500. But the data really should be in Rick Chua's hands with the technique that he was taught and his experience. What works best for Rick Chua, and how do we make that the best patient outcome and best patient experience?
So how do you utilize those technologies to essentially say, do I put in a disc? Do I put in a facet replacement? Do I put in a total joint replacement? And you will know every time, because you don't have to guess when you're going into
exactly. And as you mentioned, we could kind of go back to the pedicle screw analogy. Every pedicle screw is a pedicle screw is a pedicle screw, and they're all pretty similar. But if you don't have the right technique and you don't have the right bone graft or the right implant, you can have a horrible outcome, even though it's a great widget. So I think AI and predictive modeling, all those can help us become more standardized, which is sometimes not a fun word or phrase to say. But at the end of the day, we really should be better and more standardized for the best patient outcomes.
I couldn't agree more. I think there's one other topic that I'd love to touch on here, and this is a little bit outside of your practice on more of the philanthropic side. Would you like to talk a little bit about the Nepal Spine Foundation?
Oh my God,
I think it's absolutely fantastic.
Yeah, so to kind of put together my interest in surgeon education and my family's history of coming to this country for their education and life, I started a foundation with a friend of mine, Dr. Richard Wones, who's a Seattle neurosurgeon. He started going to Nepal about 10 to 12 years ago because of his interest in the culture and climbing and trekking and mountain climbing, which I don't have an interest in. But he asked me to join him on a volunteer mission trip to a neurosurgery teaching hospital and program in Kathmandu. And again, a cliche, it was a life-changing trip. He and I and another Seattle neurosurgeon, Dr. Faroki, went and did a spinal deformity surgery on a 45-year-old woman who hadn't walked for over 6 months because she developed a horrible thoracic spinal deformity from Pott's disease, which is a tuberculosis infection. The infection was successfully treated with medications, but she developed a horrible deformity. And so we went, operated on her, had lots of donations from industry for the implants, and performed a surgery. And less than 6 weeks later, I get a video on my WhatsApp on my phone of her walking. And it literally was a life-changing event. And so since that time, the three of us put together the Nepal Spine Foundation. We go once a year or twice a year with the idea that we teach the neurosurgeons there techniques and things that they don't have as much access to. We provide implants and other technologies that they don't have access to. And we want that knowledge to continue. So we're not just coming in and doing these cool surgeries and then leaving. We're actually leaving behind the knowledge, which is the expertise and the training and the experience. So that's been an amazing new thing in the past 5 or 6 years, and something I absolutely, put every effort into. We just recently hosted one of their neurosurgery faculty here in the United States for 6 weeks. So our fellowship was able to provide funds for him to come here. And he spent a couple of weeks in Seattle, or almost a month in Seattle, a week in Phoenix, and a week with me. And we hope that furthers the education and transfers the knowledge back to Kathmandu. During COVID, we started a Zoom grand rounds, like we did with everything else. We Zoomed. And so every 4 to 6 weeks on a Friday night, we have a Zoom with the neurosurgeons in Nepal. That's grown. We have probably over 50 people now that attend. And we have a visiting lecturer that gives a 20, 30-minute lecture on something related to spine. And then the neurosurgery residents at the teaching hospital will then show some cases. And so this sort of collaborative educational endeavor has been amazing. And I've learned, again, just as much from them as we've probably brought knowledge to them. The really super cool and fun part about our mission trip is we've now worked with a expedition company in Nepal. And this past April, a group of our doctors who went to Nepal in April were able to do the trek to Mount Everest Base Camp.
Oh my gosh.
And amazing trip. And so I'm actually going to do that trip in April for my 60th birthday.
Oh my
That's
goodness.
awesome. Oh my gosh, we have to come back after you do it.
Yeah,
and hear all about it.
it'll be amazing.
Wow.
Yeah.
It's so incredible. I think it shows the commitment that you have to bettering patient outcomes. And I think what is so, so important, it's amazing to go over and provide care, but to be able to relay the education and the training so that when you leave, there is still infrastructure in place for those patients. I think we see some of those same problems in underserved places in the United States, right? We can bring these new technologies, we can treat patients, and we get a lot of people have travel patients now. But when they go back home, do they have the same infrastructure, the same, coverage and provide the care that they need to have? And I think that's such a special thing because it's not that you're not a busy man. You've got enough going on, but to take your time and do mission work like that, I think is so incredible.
Yeah, it's obviously very fulfilling, both personally and professionally. And, we sort of got this, you sort of developed this new group of friends and colleagues, out of it, which is, again, kind of fun, life can get kind of boring, and again, you got to spice it up a little bit. And so we are, we're on group chats all the time with our Nepalese neurosurgeons and friends, and we've gotten to meet some other friends in the Maldives and continue to do that kind of work elsewhere. Not that there's not enough work here, but it is fun to sort of travel and participate in that type of thing. Every year we take 2 new surgeons, so we grow we called it during COVID. We had to stop for 1 year, but when we resumed in 2021, we talked about getting infected with the Nepali virus, which is this idea of giving back and teaching. And so we spread that virus every year by taking 2 new surgeons every year. November, December, we do an entire week of spine surgery and spine education.
That's amazing.
That is incredible. Well, we appreciate all your time. We know that you have another speaking engagement to go to as well. So we appreciate every minute you've given us. But for the people that are listening, where can they find you? If they want to have an appointment with you, if they want to hear from your resources, where can patients find you?
Probably the easiest thing to do is look me up on the Banner Health Network. And so any of the social media platforms, you can search Banner University Medicine or Banner Health. And I'm located here in Tucson, Arizona, or you can look me up at the University of Arizona. I'm certainly on LinkedIn as well, and some of the other social media sites, YouTube, et cetera. And it's pretty easy nowadays with whatever search engine you use to find me.
Perfect.
For anyone that's not on LinkedIn too, they should go search you out on LinkedIn because there is a plethora of education and materials that you put out on LinkedIn. And I think it's such an incredible thing. But we resonate with so much of what you're doing. Your commitment to better patient outcomes, your commitment to driving new technologies forward. And I think they're all coming together at the right time. But we need people that are willing to pass the baton. So we appreciate you hosting us.
Thank you guys for doing this. This is so exciting. I remember when your first episode got launched, I watched it, every minute of it, and I watched every other episode. You all are doing an amazing job too with this new platform that we have, that thing called social media. And I think the more we can educate ourselves and surgeons and industry, it all ends up being better for our patients. So congratulations. Thanks for coming to Tucson. I'm so happy to have you guys here. And maybe next time we can go out and have a meal.
We'll be back soon. Thank you so much, Dr. Chua.
Thank you.